Hello and welcome back again for talking about renal system. The renal system main by the main component kidneys basically. So let's see how is kidney designed, how does it work, little mechanism, physiology, and pathology. Let's see. This is a kidney. And a kidney right here. Kidney has three parts: cortex, there is 8 to 9 medulla there, and there is cortex. This is cortex, this is medulla, this area is called pelvis. Of course, there is a extra lining there with fatty acid and collagenous. This is called capsule. Extra layer protect the kidney. The same way it has same kidney connect with ureter. Ureter connects with urinary bladder. Urine production take place in between cortex and medulla. There is a medullary column in between, renal column. So urine produced in between medulla and cortex, and they drains like this. There is some duct here, papillary shaped duct. This is called calyx or calyces. So urine produced here, and the drainage right here, and they comes here, and from there they straight go to ureter, and it comes into the bladder. This is urethra. This is drops of urine, and we have prostate gland here. Due to age, prostate gland enlarged, and it squeezes the urethra sometimes, and urine gets little slow. So older people urine slow, younger people urines more faster and clear. Of course, this lining has very density of pain receptor. Is called nociceptor. So nociceptor is pain receptor, and this area is very painful, if any trauma or pathology. This is the basic form of the kidney, bladder, ureter, and urethra. If we go little more details, let's see how is a kidney looks like, how is designed. Let's see. This is kidney. Of course, as I told you, they have medulla. They have medulla. And ureter. This is cortex, extra layer capsule with collagen and fatty acid with pain receptor. Very painful area here if there is some pathology. Now they have some duct here, papillae. They have some duct here, papillae. This area is called actually, this is kind of papillae shape, which is nipple shape. When urine comes this area from cortex and exactly this area, so urine gets deposit this area and there is some nipple shape, this opening, very small opening, so urine can pass. This is callus and callus is okay, fine. Now urine produce this area deposits here, comes to the ureter, get into the urinary bladder. It drains like this. If any bacteria or foreign antigen these areas, so urine flow to the down, they can wash it out, drains it out. It's good. Sometimes some bacteria can ascendingly enter in the pelvis area, and that's very bad. We call it pyelonephritis. If I show you, this is hilum area. Yeah. And how does blood enters there? This is a renal artery. Renal artery. Of course, it breaks down here. There is two kidney on the right side and left side. Abdominal aorta to renal artery, and they enters at the hilum area. This hilum area. Once they enter into hilum area, they comes here, they break down into two. It gets like this. This is called interlobular artery. It's a lobe here and here. This is column, it's a lobe. Therefore it's called lobular artery. Lobular artery goes on the top of the medulla top of the medulla. This is called medullary artery, breaks down into arcuate artery. This is arcuate shape. So it's called arcuate arteries. And same way it goes like this, arcuate artery, and they comes here, and this area is venous. This area is a venous area. They get out like this. Okay, that's different story. Now see, this arcuate artery is on the top of the medulla around cortex area, and it turns into efferent arteries. Since it turns into efferent arteries, we must be thinking about some connection efferent arteries to nephron, as we know. So there should be some nephron here. Of course, there should be some nephron here, because nephron, we know, connects with the efferent artery, and efferent artery, they supply the blood with the nephron. Now let's see, this 1.2 million nephron in one kidney. In two kidney we found 2.4 million nephron. It divides into two. We found one kinds of 80% nephron in the cortex area like this, and there is also some nephron in the medullary area, which is around 15%. So the nephron is the mainly engaged in the filtration mechanism. They are the responsible to do the filtration. We call it a GFR. Let's see how nephron works. Let me draw a basic, very simple nephron. How do they look like? It's not like anatomical, it's very simple. Just for your clarification. This is Bowman capsule. Afferent breakdowns into capillaries. Capillaries break down into peritubular. Okay, and this is a Bowman space or Bowman capsule. This is efferent arteries. This is efferent arteriole, and this is the first proximal convoluted tubule. Tubule. It goes down like this. This is the tube. This is loop. Loop gets exactly back to the near the efferent artery. This is another band here. It's called secondary convoluted convoluted band, basically tubules, and they connect into a duct collecting duct. This is collecting duct, and this is basic. Same way. Another. This is medullary. There was cortical. This is medullary. It also makes a band here, bends here, and comes around. It goes way down. And make it loop. This is loop. Make another. Come back. Break down into collecting duct. That's how simple nephron. Let's see how to do the work. Make it little bigger, microscopic. Actually, let's see. Okay. Fine. This is efferent artery, breaks down into efferent arteries, very highly vascular here, this area. Fine. Okay. This is proximal conculated basement membrane. It has three alpha chain peptide here. 1, 2, 3. We'll talk about later. This is basement membrane, and this is epithelium. So 3 layers here. One, the efferent and efferent arteriole. The second one, basement membrane. The third one is Bowman capsule, epithelium or Bowman capsule. Fine. There is some cell around here, special type of cell here, this area. They're mesenchymal cell. They take place contractility and penetration. There is some pore area in the highly vascular area. This is highly vascular area. There is some poring here. This poring basically 70 to 80 nanometers. 70 to 80 nanometer. Another pore here in the epithelium of the Bowman capsule. These pores are little smaller, more microscopic. They are around 20 nanometers. What that mean? That mean the larger molecule can enter here, and once in the basement membrane there is some filtering slate there. If they even cross that way, they cannot cross this area. If they even cross this area, they cannot cross this area. So filtrate can cross only, rather than big molecules cannot cross there. It's so tightly. This is a tight junction area. Okay. What's the purpose of this whole Bowman capsule, nephron, and kidneys? The one basic phenomena we have to know. In our blood, we have so many waste product, so many healthy product. Now, waste product we don't want to be remaining in the blood. We want to excrete it in the urine. Suppose you ate 2 bananas, 3 bananas. So potassium level goes high in the blood. You don't want that to be in the blood. Our homeostasis, they want to excrete in the urine. See, this area, when blood comes, they contract here, and the penetration keep on opening. They are coming here, Bowman's. After filtration, only urine goes this area up to collecting duct. This is collecting duct. Actually it ends at the medullary papillae, as I showed you previously. Now, there is some special cell. I don't want to just draw them. They take place for reabsorption, reabsorb. They do. And our peritubular capillaries are in this area, so, and interstitial area, this is interstitial area, then the tube. So once the blood filtered, it comes here, they start reabsorb those useful components back to the blood by this interstitium to the capillaries, and they come here, another reabsorption here, and another part take place here, then the urine, the pure urine comes here. Total, there is some special cell here. Their principal cell, it's actually sodium, potassium ATPases. By the influence of aldosterone, they activates and they repel the sodium into the blood. We'll talk about later. It's not like discussable at this topic here. Now, let's come here. 20% of cardiac output comes into the kidney. So we have 5 liters of blood. If 20% comes here, which is 1 liter, out of 1 liter, the whole blood, this area actually goes for undergo filtration, and 1 liter blood basically only plasma protein undergo filtration, and the RBC, they do not. They get back to the blood. Now let's see. Here 1 liter blood, 1000 ml, 60% are plasma protein and 40% are RBC. If we deduct 40% RBC, it remains 600 ml. So 600 ml plasma protein take place for filtration. Out of that, 20% get filtered. After filtered, so 20% gets into the Bowman space and from this area to the renal duct, collective duct, so which is 120 ml per minute. 120 ml per minute. A healthy kidney can produce pure urine also pure, per minute. In 24 hours, around liter and half up to 2 liters, 3 liters can be healthy kidney produced pure urine. Now, one thing I just want to mention you guys for further clarification. It's not discussable over here, but still I just want to go for little clarification. This efferent artery, this area, there is some cells. These cells is called pulcacin. They are basically baroreceptor. There is some other cell here. This cell very densely, this is called macula densa, and they are connected by some connective tissue. The whole thing is called juxtaglomerular apparatus. We are not going to discuss about, but once blood comes here low, this pulcacin can detect the pressure of the blood, so they get activate, they start secreting renin in the blood. Renin binds with angiotensinogen 1. Angiotensinogen binds with, it goes to the lung, converts into angiotensin 2, which is vasoconstriction. And the other part, this part, macula densa, we'll talk about later. This is not the topic to discuss here. So just keep in mind, and that's it. This area if we talk about some pathological phenomena, we can say actually the pressure of the afferent artery, it depends of the filtration, Jefffer. The constriction of the efferent artery also it varies the filtration. Like 600 ml plasma protein is supposed to filter healthy kidney produce 120 ml urine. I'll come onto it later. I'm just saying that's how it could be, still okay. But this ratio cannot be less or more than there is some pathology. And let's see how and who are coming here. Ultrafiltration, which is like calcium, potassium, sodium, and bicarbonate and chlorine, and of course water comes those molecule comes WBC, thrombocytes, protein, amino acid, glucose, vitamins, electrolytes, all those are comes here. And as I told you, everyone cannot get into it. This area has a size variation. As I mentioned before, there is some poring and it has a size, it has a diameter. At the same time, over here, it has a diameter, it has a size. And those spatial cells are here in this area. There is some cells in the epithelium also. Those areas, those spatial cells, they are anionic. Anionic means negatively charged. So we can say this area is not only size barrier, it is also charge barrier. So the molecule can get into it, enter it, it has to have the proper size, and it depends also on the charge. Albumin is the real right exact size to enter on it. Sometimes they can slip into it. If they do, they have to squeeze. They have to squeeze and just enter into it. When they enter into it, actually this area get altered by some cytokines. Then they can enter into it, and they are negatively charged. So negatively charged molecule can enter into it, but they cannot be filtered. They just get into it, slip into it, and comes here. But eventually they can reabsorb it, or sometimes they go into this area. So what about the big molecule, other molecule? Can they enter into it? No, they cannot. So what happens there when they enter into it? Let's just talk about some pathological condition. How do they enter? Why do they enter? And what happens there? Let's see. Very briefly. Very briefly. This mechanism is kind of funny. You see, those products, useful products, get repelled back to the blood, and waste product get lost in the urine, excrete in the urine. When some extra protein, albumin or other components, sodium, potassium, they comes into it, they reabsorb back to the water. Yes, they reabsorb back to the blood. So what's the point? Why should I get into it? Why should I reabsorb it? But it's kind of funny. But that's how it is, this mechanism works. Let's see. By some immunological pathology, our own, this, as I told you, 3 alpha chain peptide are here. This area is collagenous, type 4 collagen. This basement membrane made by. Type 4 collagen also is another place in our lung, basically there. So sometimes our own immune system, by mistake, they attack on that in the lung and in this collagenous basement membrane area, basically this area. If they do, then there is some autoimmune pathology there in the basement membrane. It's not good for patient, but they call it good pastor syndrome. Yes, good pastor syndrome. I don't know why they call it. And some cytokine alteration, as we told you before, they alter this area. This is negatively charged, anionic. They alter this area, some albumin can slip down on it. We call it albuminuria. They get into it. Due to some injury, trauma, or some systemic pathology, this area get injured. Those pores get bigger. Once these pores get bigger, some albumin can enter into it. Basically, in the plasma protein, we find albumin, globulin, and fibrinogen. when, because of the injury, albumin can enter into it and excrete in the urine, we call it definitely albumin urea, and it has a pathological name, is called selective protein urea. Then if more injury there for becomes more bigger, also globulin can into on it. That is called non-selective proteinuria. Proteinuria. You see, now protein is leaking into the urine and excreting, so we call it proteinuria. That's fine. But what about in the blood? There is hypoalbuminemia, hypoproteinemia. Once protein level goes down, hypo in the blood, our liver secrete more protein. 3.5 gram protein. If 3.5 gram protein can leak into filtration system and come into the urine, then our liver starts secreting more protein. Okay, so it comes more protein there, non-selective proteinuria. Now what about in the blood? What's the situation in the blood? The situation in the blood is hypoproteinemia, hypoalbuminemia. Once it gets hypoalbuminemia, liver compensate, secreting more protein. Up to 10 to 12 gram protein liver can produce a day. Once liver produce those extra protein, now in our hydrostatic pressure and this is interstitium and this is venous system, back again. Hydrostatic pressure, it throws more protein in the tissue level, and if the same range of the protein the venous system are not able to suck back into the blood, or somehow due to some pathology, if the lymphatic system is blocked some reason, so extra protein deposit, very shortly I am just saying it, extra protein deposit in the tissue level, and we call it edema. So edema can be there, edema can develop there. Now all those pathology together, all those pathology together, we call it nephrotic syndrome. Nephrotic syndrome. Nephrotic syndrome. Once the other side, once this pouring more larger, more bigger, more injury allows now larger component like RBC. Now RBC also coming into this area. We call it hematuria. Once you see RBC is there, the urine color goes discoloration. Then after single cell of RBC, when they come, right after that, some more RBC can make a clot or cast, and they can come together in the big pouring area. This is called RBC cast. Hematuria coming into it. Then WBC can come in. Then complement system can come and join that, come and enter into it, Bowman space. Complement. This area, contractility and penetration, not only that, it has more function, they also can proliferate. Once those white blood cells start coming here, neutrophils and other white cells, they start proliferating this area. This area also can take place phagocytosis. They can engulf some cells if they come here. So complement system, RBC and those WBC, neutrophils, phagocytes, everybody is coming there. Now they are trafficking this area, Bowman's area. Now once those come this area and make a trafficking here, this is called actually different, crescent syndrome, crescent glomerulopathy nephritis. This syndrome actually now is acute renal failure or kidney failure. This all those pathologies is called nephritic. Nephritic syndrome. See, nephritic syndrome and nephritic syndrome, two different story. Nephritic and nephritic. Nephritic means RBC cast and everybody urinary color undergo discoloration. Nephritic, eye, we can see. When you see visibility, the different color of urine, we call it nephritic syndrome. That could be worse pathology in this topic. So there's the pathology and so on. So many pathologies are there. We just briefly discuss just some of them.